Did you hear about Sjogren's syndrome affecting your brain and your spine? Today we're going to talk about how this syndrome, Sjogren, will affect your central nervous system. So if you're newly diagnosed with Sjogren, or if you have symptoms related to your brain or to your spine that you could not understand, this might be the cause.
RheumatologistonCall.com.
When we think about Sjogren's syndrome, we think about Sjogren that is primary, not necessarily caused by a disease, or Sjogren that is secondary, associated with another autoimmune disease, such as lupus, rheumatoid arthritis, or scleroderma. Is this syndrome frequent? It is reported that about 0.1 up to 3% of the general population can develop primary Sjogren syndrome. And females are much more affected than males. And the ratio that was reported is 9-1. That means that 9 female will develop Sjogren versus only 1 male. And the age of onset, or the age when we diagnose this disease, is between 40 and 60 years. Now, what are the most common signs and symptoms of Sjogren? If you want to learn more about Sjogren and about the multitude of symptoms that this disease can cause, you can watch this video in my channel. Now, you have to understand that Sjogren is a systemic disease. It's not going to affect only your eyes or your mouth. It can affect your skin. It can affect your teeth. It can affect your stomach. It can affect your vessels, and it can also affect your lungs or your kidneys. If you look at this whole list of Sjogren manifestation, you're going to see that patients with Sjogren can develop fatigue, fever, weight loss, can develop joint pain or muscle pain. They can develop cough because of dryness in their trachea. They can develop difficulties to swallow food, again, because they lack saliva, or they can have urinary tract infections, vessels or skin involvement, but also neurological involvement. And that's what we are going to talk about today. What are the laboratory tests that we order for patients with Sjogren? We do order ANA, SSA, SSB antibodies, rheumatoid factor, anti-centromere antibodies, but not all patients will have those antibodies present. If you look at these numbers, only 80% of patients will have positive ANA. Only 60 to 80% of patients will have a positive SSA or SSB antibodies, and 74% of patients will have a rheumatoid factor present. Not only patients with rheumatoid arthritis, but also patients with Sjogren have rheumatoid factor positive. There are other tests that we do to evaluate dryness of the eyes, like Schirmer test, or dryness of the mouth, where we do measure the salivary flow, or we do a salivary gland biopsy. How do we diagnose Sjogren's syndrome? We use different type of criteria, like subjective criteria, your dryness in the eyes, or your dryness in the mouth. But we also use objective criteria, like measuring the amount of lacrimal secretion that you have, or the salivary flow, or we can do a salivary gland biopsy that will tell us if you have infiltration with certain immune cells in your salivary glands. We also test you for the antibodies, like ANA, SSA, SSB, and we use both of these types of criteria to make the diagnosis of Sjogren. Now, we have to consider certain situations that can also cause dryness. If you had, for example, lymphoma, or if you had head or neck radiation, if you had hepatitis C, HIV, sarcoidosis, if you had a transplant in your history, or if you had IgG4 disease, or if you have any treatments with anticholinergic drugs, all of this can cause dryness in your mouth and needs to be excluded before we make the diagnosis of Sjogren. How can Sjogren affect your nervous system? When we think about the nervous system, we try to be more specific, and we stratify that into the peripheral and the central nervous system. The central nervous system refers to your brain and your spine, while your peripheral nervous system refers to all the nerves that come out of your spine, and they can control involuntary body function and regulate your gland or muscles that controls your movement. How often was Sjogren reported? The symptoms of neurological involvement in Sjogren were reported in primary Sjogren since 1935. If you look at different studies, between 10 to 60% of patients with primary Sjogren will have some neurological complaints. Now, peripheral nervous system involvement is much well recognized and documented compared to central nervous system involvement, which we will discuss today. As I said before, central nervous system refers to your brain and refers to your spine. The central nervous system was shown to be affected mostly in females between 40 and 50 years of age, and sometimes the disease was there for about 10 to 11 years before those symptoms would appear, but not always. And the prevalence, or how often it was reported, was shown to be between 3% up to 80% of patients. As I already mentioned, the peripheral nervous system is well documented to be affected in Sjogren syndrome, and patients will complain of neuropathy, which could be sensory or sensory and motor neuropathy, which could involve one nerve or multiple nerves and can cause also autonomic neuropathy. Some patients can also develop myasthenia gravis. The central nervous system is affected in a diffuse way or just focal way, and you can have involvement of the brain or involvement of the spine or both. There are many studies published that they show that the central nervous system, your brain and your spine, can be involved in Sjogren, and I just listed a few here. When the brain is affected just in certain areas, you can have sensory loss, you can have motor issues, but you can also have difficulties to talk, difficulties to think. You may develop seizures, movement disorder, you can develop subacute transverse myelitis, and sometimes you can have involvement of the optical nerve. And sometimes Sjogren can look like a tumor, but is not really a tumor there. When the brain is involved diffusely, you can have symptoms like encephalopathy or dementia. You can develop psychiatric problems, or you can have what it looks like a meningoencephalitis, but it's without any infectious cause there. You can also develop an intellectual decline. You can have difficulties with your memories or difficulties to formulate ideas, and you can have also mood changes. Let me introduce you to some of the symptoms that you can encounter if you have your brain affected by Sjogren. Headaches that looks like migraine or tension-type headaches are very frequent in patients with Sjogren. Spinal cord involvement are also frequent. Seizures, motor and sensory deficits, or neuromyelitis optica. As I mentioned, headaches looks to be a very frequent complaint of patients with neuro-Sjogren. This is a table with many studies that prove that headaches, neuromyelitis optica, seizures are very frequent in patients with involvement of their brain. Now, this is another study that shows that headaches can be seen in 47% of patients, cognitive dysfunction can be seen in 44% of patients, and mood disorders are also very frequent. Depression, as I said, is one of the mood disorders that can be seen very frequently in patients with Sjogren. Sjogren can involve your central nervous system and also the peripheral nervous system at the same time. But in about 40% of cases, we do see only involvement of the central nervous system, meaning the brain and the spine. Now, what are the other symptoms that can accompany the brain and spine involvement? Here is a study that shows that neurological involvement is often associated with dryness, with pain in the joints, with pain in the muscles, Raynaud's phenomenon, severe fatigue, autoimmune thyroiditis, and less frequently with pulmonary involvement or lung involvement. This is another study that shows that patients will complain about dryness, will complain about fatigue, weight loss, joint pain, and Raynaud's phenomenon. In conclusion, neurological involvement is also associated with dryness in the eyes, in the mouth, Raynaud's phenomenon, which is a change in your hands or feet color when you expose to them to cold weather most of the time. It can associate with thyroiditis or autoimmune thyroiditis, fatigue, lung issues, and arthritis. Now, what is coming first, the dryness or the neurological symptoms? In 46% of patients with neurological involvement, this is actually the first symptom of the disease. And that is more frequent in patients that have brain and spine involvement compared to peripheral nervous system involvement. How do we diagnose neurosjogren or Sjogren involving the central nervous system? Cerebrospinal fluid or the spinal fluid analysis is very important for the diagnosis of neurosjogren. We can see certain changes like your lymphocytes being elevated there, your IgG index being elevated, but less oligoclonal bands, and we'll talk about that in a little bit. And we also do blood work. The blood work that I mentioned before, we test for your ANA, SSA, and SSB antibody. We look at your number of white blood cells. We look to see if you have more gamma globulins. We look to see if you have rheumatoid factor, complement levels. All of these are important to be tested. And what it was seen in patients that have CNS involvement or central nervous system involvement is that not all of them, they have a positive ANA, and only 38% will have a positive ANA, about 48% have a positive SSA, and only 6% will have a positive SSB antibody. As I just mentioned, in Sjogren that affect your brain and your spine, only 40 to 50% of them will have a positive SSA antibody, and only 6% will have a positive SSB antibody. And this is important because that makes the diagnosis very challenging. These type of antibodies, SSA antibodies, they actually have been associated with a more aggressive disease of the brain. What does it mean? It means that if you have SSA antibodies with neurological involvement, that could mean that you have a more aggressive disease towards your brain or your spine. We do use other tests like visual evoked potential, which are abnormal in 61% of patients. We use EEG or electroencephalogram, which sometimes has a limited value, but it can be useful to detect subclinical signs of neurological involvement. We also use MRI, and I'm going to take the time to explain to you the value of MRI in neurological involvement of Sjogren. MRIs are more sensitive than CAT scans to detect anatomical abnormalities in primary CNS or primary neurological Sjogren. There are multiple areas of increased signal that will show inflammation specifically located in the subcortical and periventricular white matter. And those lesions are found more frequently in patients that have involvement of their brain. Let me talk to you more about brain MRI findings in Sjogren. I mentioned to you about white matter lesions, and I made the comment that they have to be located in certain areas like periventricular, areas. And this makes the diagnosis challenging because some patients with multiple sclerosis, they can have the lesions in the same areas. We'll talk more about that in a little bit. In some patients, we do see signs of cerebral venous thrombosis. And in other patients, we do see tumor-like lesions that are actually not tumor, but there is a sign of Sjogren syndrome. Let's talk about spinal MRIs. Spinal MRIs are ordered to evaluate the spinal cord involvement, and they can show in patients with Sjogren intensities or hyperintensities in the cervical area. Most of the time, 82% of patients will have that problem, or they can have extended lesions in cases of acute myelopathy. This is an MRI of a patient with hypersignal in the cord that is suggestive of acute myelopathy. This is also an MRI from a patient with extensive transverse myelitis. This is also another MRI of a patient with neuromyelitis optica, a patient that also had Sjogren. This is another case of neuromyelitis optica, where you can see involvement of the dorsal midbrain and the pontine lesion in a patient with Sjogren that developed neuromyelitis optica. We also use combinations of tests like MRI and a voxel-based morphometry, and this is a method commonly used to quantitate and objectively evaluate the differences in regional cerebral volumes. This type of test was able to show that patients with Sjogren had certain areas of white matter hyperintensities, and those areas were also associated with more atrophy. These studies show that patients with primary Sjogren that have these white matter intensities and gray and white matter atrophy, those are probably related to a sort of cerebral vasculitis or inflammation in the vessels of the brain. There are other tests like single photon emission CTs or PET scans that can evaluate the blood flow in the brain. And it was shown that patients with Sjogren, they have reduced cerebral blood flow, they have brain atrophy, and decreased glucose metabolism in the brain. In certain patients, neuropsychological testing is also very important to evaluate symptoms that are very subtle in affecting the brain. Cerebral angiography is used more rarely in patients with primary Sjogren, but when it was used in 45% of highly selected patients with Sjogren and active CNS involvement, they actually shown to have small vessel vasculitis in the brain. It is important to differentiate Sjogren from other diseases, and let's talk about Sjogren versus multiple sclerosis. The brain involvement in Sjogren can mimic multiple sclerosis, and it is very hard to differentiate even for the most experienced clinicians. CNS Sjogren or brain involvement in the Sjogren can mimic a type of multiple sclerosis that we call relapsing remitting multiple sclerosis. But these two diseases, they have features in common, like they both tend to involve the brain, they both tend to involve the spinal cord and the optical tract. Let me show you some differences between neurological Sjogren and multiple sclerosis. Sjogren with brain involvement tends to affect people over the age of 40. Many of them are females, and not many of them will have clinical criteria for multiple sclerosis. When we do the spinal fluid analysis, only 30% of them will have oligoclonal bands. When we do the MRI of the brain, only 40% of these people will meet criteria for multiple sclerosis. SSA, SSB antibodies are more frequently seen in patients with brain involvement in Sjogren compared to multiple sclerosis. About 50% of patients with Sjogren and brain involvement will have these antibodies positive, while only 5% of people with multiple sclerosis will have an SSA or SSB antibody positive. Multiple sclerosis tends to appear at younger age, between 20 and 40 years old, and only 65% of these people will be female. Now, when we look at the spinal analysis, 90% of them will have oligoclonal bands in multiple sclerosis. 80% of them will meet MRI criteria for multiple sclerosis, and only 5%, as I said, will have an SSA or SSB antibody positive. There are some signs and symptoms that goes against multiple sclerosis and goes towards more primary Sjogren. For example, when both peripheral and cranial nerve involvement are affected, then that goes against multiple sclerosis. When we see less oligoclonal bands in the spinal fluid, that again goes towards Sjogren and less towards multiple sclerosis. When we see more ANA, positive SSA and SSB and positive rheumatoid factor, that goes against multiple sclerosis. And when we see Zika symptoms like dryness in the mouth and dryness in the eyes, that goes against multiple sclerosis and more towards Sjogren's syndrome. How do we treat neurological involvement in Sjogren? When it comes to treatment of brain or spine involvement in Sjogren, there is no consensus between us. We can use corticosteroids. Usually we use them in high doses when we see neurological involvement that can put the patient in danger. But sometimes corticosteroids are not effective, especially in patients with spinal cord involvement. In some patients, we do consider to use immunosuppressive therapy like cyclophosphamide or rituximab. And there are also reports about using IL-6 inhibitor like tocilizumab. However, the results are variable, and we have to adjust that to the patient needs. However, that could result in partial recovery or just to stabilize the disease. Plasmapheresis in combination with prednisone was also reported to be effective in some patients, especially patients with acute transverse myelopathy. In severe cases, IVIG was also used successfully in a small group of patients. However, the role of IVIG is more recognized towards small fiber neuropathy. There are multiple reports that show that IVIG is helpful for patients with peripheral nervous system involvement. In conclusion, neurological involvement of the spine and the brain is common in patients with primary Sjogren. Sometimes it can come before the dryness of the eyes or dryness of the mouth. Now, how often does it happen? We still don't have a very clear idea because of the heterogeneity of these studies that I presented. It could be disabling, and you have to know about this type of disease for you to call your doctor and discuss the symptoms that you have, if you have any symptoms that I presented. Now, we need more studies, more prospective control studies with larger number of patients to assess the treatment and the efficacy and safety of the treatment for brain involvement in Sjogren. And with that, I would like to thank you and wish you a very good day. See you in my next video. Don't forget to subscribe to learn more about autoimmune diseases and arthritis.
Rheumatologistoncall.com